Bismillah ar-Rahman ar-Rahim. Welcome everyone in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings and one of our clinical forums discussing clinical cases. And we are really pleased today to have and host the Oman Society of Nephrology and Transplantation to present a series of cases from their hospitals and with the team of Omanian Society of Nephrology and Transplantation. This is the first meeting after our annual Congress, ESNT 2025, and will be followed by Ramadan, inshallah. كل سنة وحضراتكم طيبين. So, in addition to hosting the Oman Society of Nephrology and Transplantation, our colleagues from Oman, this is a very special meeting that will be in between two periods of stop, one for the annual Congress and as usual, the second period of stop or for holy month of Ramadan. كل سنة وحضراتكم طيبين. I'm really pleasured to have my dear friend from old days in Cairo University, Fadi Magdi, from Oman Society of Nephrology and Transplantation. Now he is carrying this affiliation to be the moderator, co-moderator of this session from introducing his team from the society one by one. Fadi is a consultant of nephrology and medicine in Oman and now from Oman Society and Transplantation, Nephrology and Transplantation, and he is carrying the job of managing CME activities in the society. So I will leave the floor to Fadi to introduce speakers one by one, and will come, as you know all, after each case for the discussion for each case separately. Before I leave, I would like to welcome all our attending professors. Professor Hisham Al-Sayyid, President-elect of the Egyptian Society of Nephrology and Transplantation, and Professor Saeed Khamis, Professor of Nephrology and Transplantation in Menofei University, and one of the ESNT, Egyptian Society of Nephrology and Transplantation Board members. Welcome all our attendees in this session, and please listen carefully to the cases and write your questions in the chat to be discussed after the case. Thanks, Rami Abu Bakr, Dr. Rami Abu Bakr, Dr. Rami Shahat, for being the coordinator of this session and for all of his work in a CME chapter of Egyptian Society of Nephrology. So please, Fadi, take the floor to introduce the first speaker and go to the first case.
Okay. Thank you, Professor Yasser, for the nice introduction, and it is really our pleasure to join the Egyptian Society of Nephrology and Transplantation for this forum. Thank you so much for hosting this meeting, Dr. Hisham Said and Dr. Yasser Abdul Hamid and all the team and all the old friends. We are so happy to learn from you and to share our experiences together. Today we have three interesting cases from Oman. One of them is transplant case, one of them is nephrology case, and one is dialysis case. We have three eminent speakers. First, we'll start with Dr. Saja Muhammad Mahmoud. Dr. Saja is a consultant nephrologist in the University Hospital, the Sultan Qaboos University Hospital, and the University Medical City. Her favorite part of nephrology is transplantation. She's also a trainer for transplantation program, and she's a trainer in the World Kidney Academy in the cadaveric donor workshop. She has many publications in transplantation. She's one of the eminent members of the scientific committee of the Oman Society of Nephrology and Transplantation. And today she will present a case concerning some complications occurring after kidney transplant, concerning mainly anemia post-kidney transplant. And please listen carefully to Dr. Saja for the case, and then we'll leave some minutes for discussion after the case. So please, Dr. Saja, the floor is yours. Please share your screen and start, please. Thank you.
Good evening, everyone. Thank you, Dr. Fadi, for the nice introduction, and I welcome all of you for our webinar today. It will be case-based discussion about post-transplant anemia. I shared the slide already. It is appeared?
Yeah, everything is clear.
Yes. Yes,
Okay.
clear. Okay.
So let's start the introduction of one case. The slide moving. Okay.
Okay.
So let's start with the case overview. She's a 55-year-old female with end-stage kidney disease secondary to lupus nephritis. This is like 5 years back, diagnosed with lupus nephritis based on kidney biopsy abroad. And she was on maintenance mycophenolate plus prednisolone, hydroxychloroquine. However, she progressed to end-stage renal disease and she started working up for kidney transplant. Her workup, she found to have a papillary thyroid cancer. She underwent total thyroidectomy followed by radioactive iodine. This is early in 2024. And she's having been like cleared by the oncology thyroid committee for the transplant. She remained on hemodialysis for 16 months through PERMCATH, and she also have chronic anemia with baseline hemoglobin between 9 to 10.8 gram per deciliter as part of anemia of chronic kidney disease, and in between she also have iron deficiency anemia. Also, she worked up with upper endoscopy and lower scope, which was unremarkable. Then she underwent kidney transplantation July 2024 from living unrelated donor. Post-transplant course was uneventful early. Within 2 weeks, she normalized her graft function and with baseline creatine and GFR within normal. However, 4 weeks after transplantation, she got one of surgical complication reported as vascular stenosis, and she underwent stenting twice, complicated by hematoma requiring intervention and transfusion. And as per the report, she underwent maybe very frequent transfusion up 6 or 7 times. And her hemoglobin reported there as low as like 4, 5, 6 gram. Her immunosuppression, we don't know because this is class she came, usually they start induction with ATG, followed by triple immunosuppression, tacrolimus-based with full dose myofortic and prednisolone. So we saw her like 3 months post-transplantation. She came to the emergency room with progressive fatigue, with mild headache and fever, documented 37.8. There is no rash, no bruises, or no signs of active bleeding. However, she had severe pallor. And vitals recorded at the time of a presentation, normal blood pressure with the normal saturation in room air and pulse rate 95. So initial investigation in the ER showed that a stable creatine of 66 euromole per liter with GFR more than 90. However, her hemoglobin was critically low, 3.9 gram per deciliter. So further investigation, this is early post-transplant anemia. We sent hemolytic marker, all negative, but LDH was slightly elevated of 485. Haptoglobin was normal, bone profile, folate, B12, all within normal. But remember, this is all like workup done after frequent blood transfusion. And even her ferritin more than 4,000, likely due to this multiple transfusion. But we found also with this severe symptomatic anemia, she had retic count low. It is in the range between 0.1 to 0.2%, which is a suggestion of bone marrow suppression. So further investigation, we did viral screen, including CMV, EBV, PK virus with a qualitative PCR, all negative. Parvovirus B19 serology also done. It was with IgM and IgG also negative. So we are dealing with isolated severe symptomatic anemia requiring blood transfusion with low retic count. What is the differential diagnosis? You can write in the chat box, please. So when she came with this symptomatic anemia of hemoglobin around 4, we give her blood transfusion of 2 units. However, her hemoglobin remained low of 5.7 gram. Then we consult our colleague in hematology, and they ask for repeat another workup, including G6PD with hemolytic marker, all came G6PD normal activity, and it is there also negative as part of transplant workup. Again, hemolytic marker negative, peripheral blood smear reported normochromic normocytic anemia with a few elliptocytosis, no fragmented RBCs, and no platelet clumps. Again, high ferritin with high transferrin saturation more than 90% and normal folate B12 level. Being a background of SLE, we repeat her autoimmune workup, including complement, all normal. And we did the viral screen, as I mentioned, including chronic hepatitis screen, acute hepatitis screen, EBV, CMV, PV, parvovirus serology, all negative. So we are still dealing with refractory anemia with early post-transplantation. If I just brief you about what could be the possibility and the impression of this anemia, are we dealing with a nutritional deficiency like B12, folate, iron? Unlikely, because repeatedly it's normal. However, remember, this is after frequent blood transfusion. Are we dealing with bone marrow suppression? Possible. And what could be the possibility? Infectious again, maybe claimed parvovirus, CMV, EBV, but all like initial screen was negative. Drug, we should not forget drug as a cause of myelosuppression, and usually after kidney transplantation, patients have like polypharmacy, including antimetabolite like myofortic, tacrolimus, cotrimoxazole, valganciclovir, ACE and ARBs. So the patient from the beginning with this severe refractory anemia, we reduce her myofortic to half dose by 50%. So she's on 360 BID. And we also reduce tacrolimus to target the trough level between 6 to 8 nanogram. We hold cotrimoxazole and valganciclovir, and she is not on ACE or ARBs. So we are dealing with early post-transplant anemia. And if we go to literature review and the possibility of causes or the prevalence of post-transplant anemia, if we categorize to early and late, the early post-transplant anemia, it's reported in up to 90% of the cases, while late anemia, it's also still high, reported up to 45% of the cases. The mechanism behind it is common and it is multifactorial. So it could be erythropoietin deficiency, especially with graft dysfunction, which is not the case, iron deficiency anemia, drug effects. We address all these. Possible graft dysfunction. She doesn't have graft dysfunction from the beginning. Her graft normal and stable graft function. Viral infection. We did like screening of different viral possible viral infection, and so far we didn't identify any cause. So we decided with the hematology team to go for bone marrow aspiration and biopsy. And this, I was on call in the weekend, and I just counseled the patient about to proceed with bone marrow aspiration and biopsy on Sunday. Then I'm communicating with the virology from day one admission about the parvovirus quantitative PCR. Which is not yet reported. However, we have the initial parvovirus serology for IgG and IgM was negative. Then she called me on Thursday that parvovirus B19 was sky high with titer more than 2.5 million. In the first sample that we sent it on 14th of October, she admitted to the hospital on 12th of October. So this is likely parvovirus B19 induced pure red cell aplasia. And we deferred the bone marrow aspirate and the biopsy, and we decide to treat her on this line. If we go to literature review about some review about the parvovirus B19, one of the viruses that early discovered in 1974 from healthy donor, blood donor, and it is belonged to the Parvoviridae family, a small non-enveloped single-stranded linear DNA. It can affect children and also adult, and usually in immune-competent patients, it is asymptomatic or just presented with mild symptoms like flu-like symptom, or in children, the typical face rash, we call it fifth disease, and sometimes also cause like acute aplastic crisis. However, parvovirus, we should not forget that it can cause, it's one of the viruses that cause pure red cell aplasia. And if you can see here in this peripheral blood smear in the A picture, it show like reduced hypochromic microcytic anemia, while in the bone marrow aspirate, it show like reduction in the cellularity of the bone marrow. And there is in D, you can see the very characteristic, what we call it pro-normoblast with a viral inclusion body. And if you go closer, you can see this is the characteristic of the bone marrow aspirate, which show the giant pro-normoblast with viral inclusion body, which is very diagnostic and for parvovirus B19 associated pure red cell aplasia. I did literature review about how frequent parvovirus B19 associated with the pure red cell aplasia, and actually I found only like a few case report and 2 maybe case series, and the recent one, this one, which is a review article published just like 2 years back, 2022, from one of centers in China. They did like case series of 10 cases of confirmed diagnosis of parvovirus anemia associated pure red cell aplasia post-transplant. And they did literature review for over 30 years, from 1991 to 2021. And they found from this literature review of 194 cases, they found only these 10 cases. And these 10 cases, you can see most of them are kidney transplant, only 2 heart transplant. Most of them, the induction with besleximab, only 3 cases with ATG. And most of the patients, they have severe isolated anemia. And also they have low retic count, less than 1%, similar to our case. And in their case series, they didn't have thrombocytopenia, only in 1 case. However, parvovirus B19 also, it is one of the viruses that can cause hemolytic anemia, TMA-like picture, and also pancytopenia or aplastic anemia. And if we go in the same case series from the same center, they treat their cases, the 10 cases, most of them they treated with IV immunoglobulin as a standard of care treatment. And the doses, it varies between like 0.5 to 1 gram per kg. And most of them, they are responding for both IV immunoglobulin therapy plus reduction of the immunosuppression. And they have recurrence of parvovirus induced pure red cell aplasia in 1 case after like 4 months from the treatment. Back to our case, this is the chart show the treatment and the follow-up chart of the case that I presented earlier. As I told you, she presented with severe refractory anemia and blood transfusion dependent anemia with initial hemoglobin 3.9 with us. And we with blood transfusion, her hemoglobin improved a little bit to less than 7 grams. And this is the time when we start, after discovering the positive PCR of parvovirus B19 with high titer of 2.5 million, we started treatment 5 doses of 25 milligram per day. With initially we reduced her MMF myofortic to 360 BID, but you can see with the treatment there is a stabilization of her hemoglobin, and nicely upon follow-up her hemoglobin improved. And the last follow-up is 1 month back. When I saw her in the clinic, her hemoglobin was 12 grams with normal other counts, and also a stable graft function with the TAC level around 7 nanogram. I want to share with you also another literature review about this chart from one institute in India, based on their retrospective cohort study of 8 cases treated with parvovirus associated pure red cell aplasia, and according to their experience, they suggest this stepwise approach for the management of parvovirus B19 associated pure red cell aplasia, and they start mainly with the reduction of the immunosuppression. They start with 50% reduction of MMF or azathioprine, and they keep the patient on a weekly monitoring with hemoglobin level. If hemoglobin levels stabilize or improve, then they just continue observation. If the hemoglobin with reduction by 50% of antimetabolite is still falling, they suggest further reduction of the MMF or azathioprine by another 25%. If continue falling, then they suggest to stop antimetabolite at all. And if this is still no improvement, then the last resort will be IV immunoglobulin with lower doses. They use usually 0.2 gram on alternate day for 5 doses. I just share this approach because we know that IV immunoglobulin, sometimes it is not available and it is costly therapy. So maybe this is like a stepwise approach. It is in one Indian center based on retrospective cohort of their cases. So in summary, and to take home message from this case, we should keep in mind that severe post-transplant anemia warrant consideration of bone marrow disorder, and we should always put high index of clinical suspicion of parvovirus-induced pure red cell aplasia, although it is rare after solid organ transplant, but it is a treatable condition. Bone marrow biopsy and parvovirus quantitative PCR are essential for the diagnosis, and still IV immunoglobulin with reduction of the immunosuppression is a key treatment strategy. Also, you should not forget that we need close monitoring of these cases because it is reported cases of relapse. It is reported up to 17.5% of the cases. That's all. Thank you for listening, and this is my references. I'm ready for any discussion or questions.
Thank you. Fadi, please.
Thank you, Dr. Saja, for this interesting case and excellent presentation. Now the floor is open for any questions for Dr. Saja or any comments from all our colleagues. So please write your questions in the chat box, or you can ask Dr. Saja directly.
Thank you. Write your questions, please. Thank you, Dr. Saja, for this very interesting case. Professor Hisham Said wants to comment. Professor Hisham, please.
Thank you very much, Dr. Saja. Yes, it's a very interesting case. As you said, exactly, it's a very, very rare or uncommon on the literatures. And maybe if we will not look for, we will not diagnose. So diagnosis of pure red cell aplasia in general have some entities, including drug-induced, ESA doses before, and the thymoma. On the top of that is parvovirus. So I fully agree on your approach and excellent management. And as you said, exactly that we have to follow up as the relapses is very common. Thank you very much.
Thank you.
Thank you, Dr. Saja, and thank you, Fadi, for a really very interesting case. It seems that
we have a question, Dr. Yasser, in the chat box. One question is, should we screen?
Okay, I will. طيب.
Okay, تفضل.
لحظة تفضل. Should we screen for parvovirus before transplantation? What is the time to consider from Sarah Khalid? And from doctor, please write your name. What is the time to consider failure of immunosuppression reduction protocol in parvovirus-induced red cell aplasia?
Thank you for the first. I will answer the first question about what is the time frame for the considering resistance to treatment, right? Or reduction of the immunosuppression.
Yes.
Actually, I forget to mention that most of the patients they do response within 2 weeks of the initiation of IV immunoglobulin. And even in our case, within like 2 weeks, first week stabilization of her hemoglobin, and within 2 weeks, we saw that her hemoglobin start to improve. So this is, we are monitoring with the hemoglobin and also monitoring the parvovirus PCR level together. So we are doing in our center, we are doing every 2 weeks monitoring of the viral PCR plus the hemoglobin level. Cases of relapses, it is reported, the evidence is very limited for case series and case report, but when I review it, it is just I mentioned there is a possibility of relapse within few months, reported 3 months. It can be relapse. I do share one case seen earlier with Prof. Nabil Mohsen of parvovirus-associated pure red cell aplasia, and we treat him with IV immunoglobulin with a reduction of the immunosuppression, and he did relapse after a few months, and we reintroduced IV immunoglobulin again for this patient. Then he went to complete remission. Regarding screening, we are not screening patient with serology of parvovirus because it is rare. At least in our center, we are not screening. I don't know at Royal Hospital, it is not part of screening or our transplant workup. But from now, we should put high index of clinical suspicion of risk in immune compromised patient. This patient, to start with, she's immune compromised. She's the SLE, and she was treated before with long duration with MMF and the steroid. So maybe this is also a lesson to us, maybe such immune compromised patient to start with, we should consider parvovirus screen. This is not with good evidence, but observation. Hopefully I answered the question.
I have a comment, Dr. Saja, if you allow me. In Royal Hospital, we are not doing screening pre-transplant for parvovirus.
Yeah, we do so. We are not doing.
Because, I think it will not affect your decision regarding transplantation. It just will affect your frequency of monitoring post-kidney transplant. And again, it's very costly investigation, and most probably once the patient starts to have some kind of viremia, he will present like anemia. So I think for cost benefit, screening for selected cases, once we have some kind of anemia, it will be more practical wise.
One more thing I want to add, I think serology, it will not add because it is non-sensitive, non-specific, and similar to our case, we screen her with serology after suspicion, and it is negative, but parvovirus quantitative PCR is more specific, and it is costly. We are sending abroad this test. I don't think it is available in whole Oman.
دكتور فادي ممكن كومنت؟
اتفضل.
هو حضرتك بس انا ريجاردنج ان الكيس بتاعتي ان شاء الله تكون على اونكو نفرولوجي، فاي نوتيسد ان في جود سترونج كورليشن بتوين الكانسر اند فيرولوجي. فالبيشنت دي جالها بابيلاري ثيرويد كانسر just before transplant.
Yeah, but it is papillary cell cancer. It is with 95 to 99% cure, and it is.
لا انا اقصد I mean ان maybe we can detect one of the cause of the cancer is papillary virus. If we screen, it is very difficult, but I think maybe there is a relation between this cancer and papillary virus.
Fadi, please.
Okay. Now we have a question here from. Sorry.
There is a comment in the chat, and I have a comment, please.
Yes, please. Please, Dr. Yasser, اتفضل.
Dr. Saja, your protocol was to decrease immunosuppression first and then IgG, صح?
No, this is the one of Indian protocol. It is center-based based on their retrospective cohort study. They suggest a stepwise approach for the treatment of parvovirus B19. For us, we treat her with IV immunoglobulin. With this symptomatic, severe blood transfusion dependent, she received almost, like I can tell you, maybe 10 units of blood between the center that she transplanted and with us. And with barely her hemoglobin came with us with 4-gram hemoglobin initially when we saw her in 3 months after transplantation.
Okay, as you said, we don't meet this case usually in our practice. It is a rare case. So,
yeah, rare case, but I can tell you in my experience in Sultan Qaboos University Hospital, I'm 15 years old. I'm 15 years now in the practice. I saw 5 cases.
Okay, so it's not that rare, but usually in our practice,
and all kidney transplant, transplant.
Any concern about recurrence leading to modulation of immunosuppressive protocols for using some weaker anti-immunosuppressives? For example, if you have such large number of cases, any recommendations to modulate your immunosuppressive protocols in one kidney transplant recipient who had such a severe parvovirus before?
Really, we don't think this patient have it before because her baseline hemoglobin was 910 before transplantation. But parvovirus,
I mean
yeah,
the possibility of recurrence.
Intense immunosuppression can cause, especially to start with this patient, she had autoimmune disease and she was on prolonged immunosuppression before. You mean it depends because this is again, we don't know the donor mismatch between the donor and the recipient and how many doses of ATG have been received. And for us in University Hospital, we use tacrolimus base with mycophenolate, triple immunosuppression. Being lupus nephritis to start with, should be on triple immunosuppression. And this patient actually, now she is within 3 months, she's on half dose of mycophenolate, 360 BID with tacrolimus good dose, but she's doing well. I assume her ATG, it was inducted with ATG, this lady.
Okay, a question on the chat explains what I mean. Do you any suggestion for the use of sirolimus or rapamycin or something like this in this patient instead of?
I think sirolimus also can cause pure red cell aplasia. One of the causes of anemia post-transplant.
Viral, and in this case with
consider it as alternative.
In this case with viral infection and malignancy.
Her malignancy type, it is with high cure rate, and she's underwent total thyroidectomy followed by radioactive iodine, and she's cleared from the oncology center to go for transplantation. But regarding shifting her, she's only now less than 6 months post-transplant. To shift her for sirolimus with this like pure red cell aplasia, I don't think it is good option.
Okay.
We kept her on half dose myofortic, and we target lower TAC level. We target like 6 to 8 in the first 6 months.
Okay, so please, Fadi, would you move or would you like to add something?
Thank you, Dr. Yasser. I believe the case now is clear, and I believe we can move to the next case.
Okay.
Welcome again for the interesting case presentations by the Oman Society of Nephrology and Transplantation in collaboration with Egyptian Society of Nephrology and Transplantation. We have now the second case for a complicated case of hemodialysis. It will be presented by Dr. Ahmed Atris. Dr. Ahmed Atris is a very active member of Oman Society of Nephrology and Transplantation. He's the General Secretary for the Society. Dr. Ahmed has his master's degree in Egypt and nephrology fellowship from Ministry of Health in Egypt. He also has intervention nephrology fellowship from the ISN and he's interested also in point-of-care ultrasound regarding echocardiogram and AV fistula complications. Dr. Ahmed today will present an interesting case having some viral complications, malignancies, and furthermore. Dr. Ahmed, please start, and please all colleagues take care of this lecture. This is really interesting. Thank you.
Thank you, Dr. Fadi. Thank you, Dr. Yasser. And for all, Bismillah ar-Rahman ar-Rahim. Regarding our case today is a long journey of onconephrology with hemodialysis patient. This is very rare case, but very interesting. And our male patient is 38 years old, Omani male with known case of hypertension and end-stage kidney disease on a regular thrice weekly hemodialysis session since January 2011. He had interesting past medical history. It started in 1993 when he was 11 years old age, and he was found to have an osteosarcoma of the right tibia, and he underwent right below knee amputation in United States. Then after about 7 years later, in 2000, when he was 18 years old, he developed the osteosarcoma in his left femur and underwent left above knee amputation and got chemotherapy. So a patient at 18 years old has two amputated of the two lower limb. This was complicated by chronic kidney disease that progressed gradually into end-stage kidney disease and started hemodialysis in the early of 2006. Later that year, he underwent a kidney transplant, living unrelated in Pakistan. His kidney function was suboptimal, and CKD progressed again towards end-stage kidney disease. He underwent graft nephrectomy in December 2010 after recurrent graft infection, and finally he was initiated on hemodialysis since January 2011. This is the first part of the journey of the onconephrology with osteosarcoma. A patient in 2020, another episode of journey of oncology. He was diagnosed COVID-19 in July 2020, and after he presented with fever and diarrhea, he presented with mild to moderate infection, so he was not admitted to the hospital, but he was remained at home. He was quarantined for 2 weeks and attended the medical center thrice weekly for dialysis in an isolated room at our dialysis center. During that time, he presented to the cardiology outpatient clinic with exertional breathlessness associated with retrosternal chest pain. During clinical examination, his physical activity was limited as he walked with an aiding stick. After artificial limbs were done, so functional capacity couldn't be fully assessed by the attending clinician. His ECG showed a normal sinus rhythm with left ventricular hypertrophy. Then patient doing chest X-ray revealed cardiomegaly with no abnormalities in both lungs. A new echo compared to an old one done in 2019. The old one showed upper normal left ventricular size with intact function. Ejection fraction was 55%, but the new one, ejection fraction reduced to 35%. And the diagnosis as HIF, RIF, heart failure with reduced ejection fraction. Also, other abnormalities in the echo, like concentric left ventricular. This previous slide, sorry. Also in the echo, there is concentric left ventricular hypertrophy, dilated left atrium, and Roma, regional wall motion abnormalities in the form of hypokinesia, and the whole anterior wall and basal interventricular septum, basal inferior wall, basal posterior wall, grade 1 diastolic dysfunction, and justly diagnosed as dilated cardiomyopathy. Next slide. The cardiologist impression was dilated cardiomyopathy with deterioration of the left ventricular function, which could be due to either acute viral myocarditis or coronary artery disease. So in the next month, in 26th of August, he underwent coronary angio, which revealed normal coronary arteries. The myocyte necrosis marker showed a high troponin I level, about 200 nanogram per liter, normal less than 50, and creatinine kinase level mild increase 223. The myocarditis is diagnosed by exclusion regarding clinical presentation and elevated level of biomarkers and of myocyte necrosis and the normal coronary arteries. So the final diagnosis regarding cardiology was acute viral myocarditis associated with COVID-19 infection. After that, 1 month later, his voice was changed. So he was referred to ESNT clinic. By examination of the neck, there is enlarged thyroid lobes and cervical lymph nodes were identified. Neck ultrasound scan showed bulky thyroid gland with heterogeneous texture, fairly defined hypoechoic nodules in right and left lobes with multiple cervical lymph nodes calcification. The next CT scan advised showed enlarged thyroid lobe and calcified cervical lymph nodes. A fine needle aspiration and fine needle cytology was taken from right and left nodule reported as thyroid follicular cells with cytological atypical RC. Also, an initial fine needle aspiration taken from the level 3 left cervical lymph nodes reported as non-specific. Differential diagnosis includes parathyroid lesion versus thyroid gland follicular neoplasm. So parathyroid scan was done and was negative for parathyroid adenoma. So reported fine needle aspiration revealed thyroid gland follicular neoplasm. This is not the end of the journey. This is a summary of what has happened in the year of COVID. The patient accepted COVID. Then during the first 2 weeks, have chest pain and cardiac consultation. Also have voice changes and ESNT consultation. Coronary angio exclude coronary artery disease, and CT thyroid and fine needle aspiration diagnosed as follicular cell carcinoma. So total thyroidectomy done in January 2021, and improve cardiac state of the patient after that. Last of the journey was from 5 months back. On September 2024, he had generalized bony pain and developed multiple pathological fractures in the upper limb, included طبعا الارم of the dialysis fistula. Biopsy was taken from it, showed recurrent metastatic osteogenic sarcoma. The patient treated as palliative, and after 3 months, admitted in the ICU with severe anemia, hemoglobin can less than 6, with septic shock and confusion, arrested in 19 December, and then declared this at 4 p.m. The first part or second part of the story, doing as paper COVID-19 associated with acute viral myocarditis and thyroid gland follicular neoplasm in hemodialysis patient. So my comment about the case of Dr. Saja, and maybe papillary thyroid carcinoma كانت induced by human papilloma virus. So we should be suspect in patient with history of cancer in the screen regarding the most common virology induced cancer as human papilloma virus. This our paper regarding the story of the patient during the COVID and how is COVID may be associated with viral myocarditis and thyroid gland follicular neoplasm. Also, under supervision of Professor Isa Salmi and with help of Professor Basim Bahrani, consultant of oncology, we're doing epidemiology of cancer among chronic kidney disease patients in Oman compared to the general population. This study done in the Royal Hospital, the big tertiary hospital in Oman, during January 2006 to December 2019, all patients with CKD and those on regular dialysis who are admitted in the Royal Hospital were included for evaluation of malignancy. Result of study, we collected about 2,500 patients with CKD, and only found 25 patients were found to have different type of cancer. 13 was male and 12 was female. Most of patients, 13 patients were senior adult, and 11 was adult, and 1 only child. Cancer was detected in female in ovaries. Then other cancer was stomach, multiple myeloma, and renal with 12%. While breast and colorectal cancer, 1 male and 1 female. Also, parathyroid and thyroid, uterus, cervix, prostate, skin, liver, all these cancers, 1 case only. In general population in Oman, breast cancer is the most common cancer among female, followed by thyroid cancer and colorectal cancer. While most common cancer types among male in Oman is colorectal cancer, followed by prostate and non-Hodgkin lymphoma. So our conclusion, this epidemiological finding should prompt clinician and health authorities to assess strategies for cancer screening in high-risk population of CKD patients. يعني when we deal with our hemodialysis patient or CKD patient, we should put in mind any maybe cancer or oncology itself have big chance with this patient. This is our health minister, Dr. Hilal Sabti, in the opening of the first international conference of Oman Society of Nephrology in Salalah in 2023. And this is our program with highly appreciated to Professor Hisham Said regarding this program. we finished the first module, renal replacement therapy, and he announced about the second wave of renal replacement therapy and blood purification, which will start in June 2025, included extracorporeal blood purification, CRRT and TBX and BD, HD and HDF and clinical challenges. It will start, inshallah, in June 2025. And this is finally my announcement about the third annual International Conference of Oman Society of Nephrology and Transplantation. Inshallah, it will be in the end of this year in a nice city in Oman, Sohar city. And thank you.
Please, Fadi.
Thank you so much, Dr. Ahmed, for this interesting case. I know that the end of the case was sad by the death of the patient, but I believe, as you just said, we have to maybe pay much more attention about cancer in CKD and dialysis patients, in addition to the usual things we are looking about: cardiovascular problems, bone disease, and anemia, and so on. So I believe the message from this case is clear: is to put cancer in our minds when we are reviewing patients on hemodialysis. So the floor now is open for any questions. So please write your questions in the chat box.
There is a question from Dr. Ali. Adriamycin, if included in his chemotherapy protocol, may be the culprit for dilated cardiomyopathy.
بس الكيموثيرابي دوت كان 2006 والبيشنت ديليت كارديوميوباثي 2020 complicated للكوفيد فيروس.
Complicated. Yes.
كان البريفيوس حضرتك ايكو كانت 2019 كانت نورمال ejection fraction.
Yes, in the COVID era, really we so many cases of cardiomyopathy following this infection. Generally, infection is the cause of dilated cardiomyopathy, viral infections, but it was there was a peak or increase in the incidence following COVID era. We saw all this. Okay, Professor Saeed Khamis, please unmute yourself.
Thank you, Professor Yasser. Thank you, Dr. Ahmed, for this very interesting case. Actually, I do agree with you to have a high index of suspicion when dealing with a hemodialysis patient regarding the cancer incidence or occurrence. But I do not agree with you regarding the universal recommendation to screen the patient or hemodialysis patient for different types of cancer. Up till now, there is no consensus to screen the patient or the end-stage renal disease patient or on hemodialysis for cancer compared to the non-uremic patient, because they calculate it in another way. I mean, the cost-benefit. So we cannot say, as a general statement, we should or we must screen these people for cancer. But we should keep in mind, as Dr. Shadi said and you said, when we deal with patient such cases, to put in the differential diagnosis the cancer issue. This is my comment.
Thank you, Professor Saeed. Dr. Fadi, we do not have any other questions and no other comments, so we can move.
Yes, please. We can move to the second. Thank you, Dr. Ahmed, for the presentation. And now, I believe you had a question, Dr. Yasser. Can we?
Okay, go ahead.
A question from Dr. Mujahid. I think what he developed is MIS with widespread systemic inflammation, with his baseline immunosuppression, chronic inflammation, and cardiovascular risk.
Okay, this is a comment, not a question.
Yes.
Okay, thank you, Dr. Mujahid.
Okay, welcome back again to our meeting with Oman Society and Egyptian Society of Nephrology and Transplantation. Now we are having the third case, and it's an interesting case also for metabolic problem in patients with CKD. It will be presented by my colleague, Dr. Shayma El-Shidi. Dr. Shayma is a nephrology consultant in Sohar Hospital. Sohar is a beautiful city in Oman. She has her internal medicine specialty from Oman's Medical Specialty Board in 2018. And Dr. Shayma also has a fellowship in nephrology from the University of Toronto in Canada in 2022. Dr. Shayma is an active member of the scientific committee of the Oman Society of Nephrology and Transplantation. Dr. Shayma, please start. Thank you.
Thank you all for the invitation. Today I'm glad to present a interesting case of general nephrology and critical care. So Mr. Aras, he's 60-year-old, previously fit non-insulin dependent diabetic male. He was brought to the emergency department to Sohar Hospital by family, semi-conscious at home, complaining of severe central abdominal pain. His past medical history include diabetes on oral medications and stable ischemic heart disease. His social history, he's smoker and alcohol consumer. He was on the following medication: glibenclamide 20 mg per day, metformin 1 gram BID, and valsartan 80 mg OD. On examination, he was confused. His blood pressure was elevated 180/112, and his heart rate was 112 beats per minute, and his respiratory rate was 24.
معلش بليز دكتورة شيماء شوية شوية.
Oxygen saturation was 98% in warm air. He had a low blood sugar at presentation of 3.2 millimole per liter, and he was giving dextrose IV. The abdomen was flat, soft, with no tenderness, and the liver and the spleen were not palpable. His conscious level deteriorated during admissions in the emergency, and his GCS also dropped. He required emergency intubation. Showing to you here his lab at the presentation, which is really available at the few minutes at the presentation to the emergency. It's a venous sample. His pH was low with 6.7, and his PCO2 with compensations of 30, and his bicarb was very low of 4. His serum lactate was of 13. So at that point, he was diagnosed with severe lactic acidosis. Additional lab shows that his hemoglobin was normal and his white cell counts was almost normal with mild elevated in the neutrophils of 6.9, and his CRB was 59. Additional labs results show that he has severe renal impairment with a creatinine over 1,000, and his potassium was 5.9, and confirmed the metabolic acidosis with a bicarb of 2. Going back to the patient history, baseline kidney functions 2 months prior to the presentation was normal, and his creatinine was 64 with the eGFR more than 90, and his radiological investigations, bedside echo, showed that his left ventricular contractility was preserved and inferior vena cava did not collapse. Ultrasound was showed normal kidneys, and also with this presentation of normal blood pressure and severely elevated lactic acidosis and abdominal pain. So CT with a contrast to rule out bowel ischemia was indicated, and has been done and was normal with no evidence of bowel ischemia. So impression at that point, we are dealing with the patients with based on physical and laboratory and ultrasound findings that the patient did not have circulatory failure or severe or tissue hypoxia, and we are dealing with lactic acidosis mainly because of type B lactic acidosis, and a patient who is taking metformin. So the diagnosis of metformin-associated lactic acidosis was made and decided to be started in hemodialysis for immediate management, followed by intensive care unit admission. So this is my talk for today about metformin poisoning, or what is known as MALA as well, metformin-associated lactic acidosis. Going to the history of metformin, it's come from the medieval Europe. It was by using the French lilac as treatments for patients with diabetes, and the active component of this French lilac was the bigonide. And in the late 50s, the bigonide has been used to made 2 pharmacological agents for diabetes, the fenformin and metformin. And the fenformin has been taken out from the market in the 1976 because of associated severe lactic acidosis, and since then metformin became the principal bigonide as anti-diabetic medication. And still, till now, metformin is considered as the first-line treatments for diabetes in most of the guidelines. And going to the details about metformin, it is cheap, so widely available in most of the countries of the world, and it is have also effective in lowering blood sugar, and also had effect on reducing weight. And however, there is because this metformin is renally excreted, it's tend to accumulate with patients with renal impairments, and is contraindicated to be used in the patients with severe renal impairment with eGFR less than 30, and with the patient with CKD stage 3 using lower doses of metformin. So lactic acidosis associated with metformin is rare but serious adverse effect of metformin. And most patients occur because patients started in metformin who have a contraindication that was overlooked by clinician. Here, going to 90s, that the exclusion criteria has been developed to not to use metformin in patients with renal impairment, although the parameters has changed. We are accepting a lower parameter of renal impairment to start metformin, cardiac respiratory insufficiency, has history of lactic acidosis, severe infection, liver disease, include alcohol liver disease, alcohol abuse, and use of IV contrast. About the incidence, that showing the existence of this, the evidence of the existence of metformin-associated lactic acidosis is the acute overdose, that the incidence is up to 26% in patients intentionally overdose of metformin. However, in a chronic patient using metformin, it's very rare. A systemic review of over 300 trials and cohort study shows that it's very rare disease, about 4.3 cases per 100,000 patients a year. Here showing you records of patients in UK with metformin overdose who was taking metformin only, and you can see that the incidence about in patients, about 117 patients isolated metformin overdose, the incidence is about 26%. Talking about the developments of metformin-associated lactic acidosis, it goes to the mechanisms of actions of metformin. Metformin can precipitate lactic acidosis in two ways that inhibit the enzyme involved in the gluconeogenesis, and by preventing pyruvate carboxylase and preventing the pyruvate conversions to glucose. And in another way that inhibit the mitochondrial electron transport chain and increase the conversions of pyruvate to lactate, which is more available at that with the inhibitions in A, as you can see here in the figure, and the pyruvate is more available and is converted to lactate. And in insults like cellular hypoxia or congestive heart failure, respiratory insufficiency, or sepsis or shock, the lactate also is increased with the fact that the patient is on metformin or metformin is accumulating, also is contribute that prevent the conversions of lactate to glucose. So lactic acidosis in metformin therapy, it can be as a causation, contribution, or innocent bystander in a patient. And the patient presented with metformin with the severe lactic acidosis with the background of metformin use. Just to introduce you to the topic, to the terms of metformin-induced lactic acidosis, which is in a case there is no known additional condition that could lead to lactic acidosis at presentation, and the patients have confirmed high plasma metformin concentration, and there's good evidence that there is suggestive of metformin accumulation based on patients' metformin use, like renal impairment or acute kidney injury. Metformin-related lactic acidosis, on the other hand, there is a good evidence of intercurrent illness that causing severe lactic acidosis, there is low evidence of metformin, low evidence, or assume that the patients have low evidence of metformin concentration. And the metformin-associated lactic acidosis, which is most of the cases, is diagnosed as metformin-associated lactic acidosis. There is insufficient information to rule out metformin involvement, as in our case. And here showing you the graph that to the right side, you can see that with the patients with the very high metformin accumulations and a high lactic acidosis, that's happened in the patients with acute overdose. And in the other extreme, that patients with the low metformin concentration or patients not taking metformin or no evidence that the patient is taking metformin with a high lactate, which just happens in a patients in multiple severe condition causing lactic acidosis, and in between, in the middle, that metformin association cannot be ruled out. Other evidence that here showing you the other evidence that the patient, the metformin can contribute to metformin associated lactic acidosis here in a case series, that you can see that with the increased metformin, when they measure the serial metformin in the patients admitted with suspected metformin associated lactic acidosis, that with the decrease in the metformin concentration, there is a decrease in the creatinine concentration, and also a decrease in the lactate concentrations and improvement in the pH. So this is another evidence that metformin associated lactic acidosis exist. And another evidence that here they look into a case series in Italy, about 66 patients in the emergency department presented with metformin associated lactic acidosis. And you can see that there is although it was not a strong correlation, but was significant correlations between plasma metformin concentrations and the blood arterial lactate level. So there's multiple mechanisms can trigger metformin-associated lactic acidosis, like hypoxia, like dehydrations that lead to acute renal failure and accumulations of metformin, overdose itself with a very high dose of metformin, and like a disease like contrast exposure or NSAIDs use. Regarding the clinical manifestations, you can see
1 minute, 1 second, please. دكتورة شيماء, 1 second, please.
Sorry, I was mute.
Okay. Yes. Okay.
Whole presentation.
Go ahead.
Hello.
اتفضلي.
I was mute whole presentation.
No,
No.
we heard you clearly. Just a couple of seconds.
Okay. Somebody mute me maybe or something.
Maybe
Okay.
technical error.
Okay. So the clinical features of metformin in patients diagnosed with metformin-associated lactic acidosis, that there is a significant number. You can see that the patients, about 53% of patients, have a contraindication to start with to be in metformin. So from that, we can see there is a poor patient selection. And also there's another information we can gain from that even in patients with no obvious contraindications for metformin use, still metformin-associated lactic acidosis can present. And you can see the clinical features, usually GI symptoms, non-specific symptoms that can be mixed with other diseases, like with hypotension, bradycardia, arrhythmia. And these also can be, these presentation can be mixed mainly with sepsis, which is most common presentation to the emergency department. And in this study, they found early mortality about, which is mean that the mortality before discharge from the emergency or the ICU was about 26%, 17 patients died. And in comparing patients who survived or died, there was no significant differences between metformin and lactate concentrations. So we didn't know, it's not related to the metformin concentrations or severity of the lactic acidosis. And there was no differences between the survivals and non-survivals, between latency, between access to hospital and start of dialysis. So diagnosis in literatures is defined as elevated serum lactate concentration in conjunctions with taking metformin. Is that enough to diagnose patient? You can see that elevated lactate, they have so many differentials, and most importantly is with a high mortality is the sepsis. The clinical symptom, as I showed, is similar to sepsis, and it's also accompanied by organ dysfunction. But however, the treatment is different in patients with metformin-associated lactic acidosis than sepsis. For example, the dialysis is essential in MALA, however, not in sepsis unless there is an indication. So information about metformin use sometimes not really available at that admission to the emergency department, and measurements of metformin serum concentration not routinely available in most hospitals as in our hospital. Here in a study in Netherlands, they wanted to how we can improve the diagnosis of metformin-associated lactic acidosis in comparison to sepsis. And they look into the differences between a patient suspected, not necessarily confirmed sepsis-induced lactic acidosis, the number of 90 patients, comparing with the patients with the confirmed metformin-associated lactic acidosis, they confirmed with the blood sample for metformin. They compared 90 patients to 13 patients, and they can see that the difference is that the creatinine was much higher in patients with MALA, and lactate also was high with a lower BH, and the CRB was even significantly lower in patients with MALA, and Apache score was, which is indicates about indicating of for mortality, that it was similar between sepsis suspected and MALA. However, and the use of extracorporeal treatment therapy was higher in patients with MALA for sure, and the mortality, although they have similar Apache score, the mortality was higher in patients with MALA compared with sepsis. And they wanted to look into a number that can indicate metformin-associated lactic acidosis over sepsis-induced lactic acidosis. And they come up with a number of lactate more than 8.4, creatinine more than 256, and metformin use to identify that. When they combine the lactate and the creatinine, this number, they had a sensitivity about 84.6. And when you add to that information the use of metformin, the sensitivity is the same. However, the specificity was very high, up to 99%. Talking now about the management, as usual in any critical patients, to secure the airway, breathing, and the circulations. In a case of acute overdose, is to use activated charcoal. However, which cannot be used in patients with a chronic metformin user, and in the patients with profound acidosis, try to use patient sodium bicarb to correct the acidosis with its limitations, and then assess the patient to use of dialysis or extra corporeal treatment, replacement therapy. Going to the more information about metformin, is a candidate for to be cleared by dialysis. The molecular weight of metformin of about 165, which is not that big. Volume distribution is large, about 1 to 5 liters per kg. However, it is not protein bound and water soluble, so it is a good candidate for clearance by extracorporeal treatment. Here, the extracorporeal treatment in poisoning workup recommendations was to use the dialysis, the aim to remove the metformin, clear lactate, and correct acid-base abnormality. And they recommended that to be used in a patients with severe lactic concentrations or severe acidosis, and also suggested in a patients who have moderate, like less severe lactic acidosis with a lactate between 15 to 20 and a BH, less severe BH with a combined with other indications like impaired kidney function, shock, or decreased level of consciousness or liver failure. And to stop the treatment once the lactate concentration less than 3 and BH more than 7.3. The questions come next: which modality you will use? Here, they presented the pharmacokinetics of metformin with the dialysis, and you can see with the hemodialysis that the clearance can up to 200, and with the CRRT about 9 to 71. So hemodialysis is more preferable in clearing the metformin over CRRT. So back to the case, see, patients, he had the first dialysis was in the emergency department. Once he was in the ICU because of hemodynamic instability, he had a CRRT session followed by IHD. On discharge, his creatinine was 290, with 2 weeks follow-up was 139 with the eGFR of 47, and his pH on discharge was normalized with the lactate 0.8. There was no history of chronic kidney disease and the outpatient serum. But going to the details of this patient, the question was what was the trigger for this patient to go into metformin-associated lactic acidosis? There was no history of chronic kidney disease. Baseline kidney function a few months ago prior to the presentation was normal. And however, when patient regained consciousness, further history taken from the patient, he had an excessive alcohol consumption. So how come the excessive alcohol consumption become a trigger in MALA? Again, presenting to you the same diagram before, and you can see that the ethanol using the NAD for oxidation. So with that, the NADH become more prominent over NAD, and this is favor the conversions of pyruvate to lactic acid. And here how the excessive alcohol consumption can trigger MALA or contribute to the MALA in this patient. So our diagnosis at the end of discharge that the patient have alcohol-induced MALA. What's the impacts of this case in practice? MALA is rare, reported in patients with normal kidney function. Clinician must be alert to the exclusions criteria for use of metformin, especially the alcohol consumption. And this patient, he did not disclose the excessive alcohol intake to his primary physician. And clinician should be also alert about MALA in the emergency department, especially in the patients with a very high creatinine and lactate concentration. Early recognition of metformin-associated lactic acidosis and timely starting treatment may reduce morbidity and mortality. And thank you.
Thank you so much. Please, Fadi, have a comment?
Thank you, Dr. Shaima, for this interesting case. In fact, in my whole life, I have never seen a single case of MALA. I believe it is really rare. Even I have seen patients having metformin CKD stage 4 or stage 5, even by mistake, and they did not develop this sort of acidosis. It seems it's really rare. So any questions?
Interestingly, in my practice, like about 2 years in Zohar, after I finishing my fellowship, I have seen 2 cases of MALA. Maybe the suspicion, like you really to suspect MALA so you can diagnose, because we usually don't do metformin level. So so this incident that I think maybe the incidence is higher than that is presented in literatures, because you need really low threshold to diagnose it.
Do you follow up the patient now?
Yes. Actually, he recovered his function normal, but later on he was brought to the emergency department. I think 2 years later, he was hit by a car and he passed away. Of dialysis again, actually about 2 years at that time when he had the accident, his kidney functions was normal.
Okay. Regarding your outcome, congratulations for this outcome for such a known fatal condition with metformin-associated lactic acidosis in treating the patient and reaching a baseline normal serum creatinine and discharge.
Another interesting point that I went through the literatures about metformin-associated lactic acidosis, the cases with alcohol-induced in particular, they have very good outcomes. Usually, there was no reported case of mortality with alcohol-triggered metformin-associated acidosis.
Thank you so much. Now we have no more comments. And no more questions, Fadi. So I think
one comment, Dr. Yasser, if you allow me.
تفضل Professor Saeed.
Thank you, Dr. Shaima, for this very interesting case. I just wanted to highlight 2 points. One very basic point to my junior colleague. When I find any patient with severe hypobicarbonемia, I mean very low bicarb, in an advanced renal failure like this patient, I should think that another added insult is there, because as per evidence, I mean evidence-based, that uremia, whatever the severity, it will not lower the bicarb below 13. Once it is below 13, I should think in another added factor like sepsis, I mean lactic acidosis due to sepsis or whatever, DKA or whatever. That's number one. Number two, I faced one case when I was working in the Gulf area, such almost the same like your case, but with more sophisticated problem. I mean, he has also severe hemolytic anemia, resistant to blood transfusion. And I went through the literature at that moment, and I found some reported cases, case report with metformin-induced hemolytic anemia plus this MALA. Unfortunately, we did the best with this patient, like you did the best with your patient, but our patient already expired, because it was severe presentation, especially the anemia was very resistant to blood transfusion. So sometimes it comes also with severe hemolytic anemia, I mean MALA. So this is my 2 comments, and thank you so much.
Interesting case. And
Thank you.
usually the cases of mortality in MALA, it's really related to the comorbidities as well.
Yeah, you're right. And even we checked at that moment, it was very prestigious hospital when I was working there. We checked the metformin level. It was very high, actually. So it was clear that the metformin is behind this issue. But unfortunately, the patient expired at that moment.
Okay. I think I have a comment from Dr. Mujahid. Okay. No more comments, Fadi. And
No. Okay, I believe now we come to the end of the meeting. Thank you so much on behalf of Professor Isa Salmi and all the family of the Oman Society of Nephrology and Transplantation. We offer you our thanks for sharing us this meeting. Thanks for Dr. Hisham, Dr. Saeed, and Dr. Yasser, and my dear friend Dr. Rami for allowing us to chair this meeting. Thanks for all the eminent speakers, Dr. Saja, Dr. Shema, and Dr. Ahmed Atris, for the interesting cases, and thanks for all the audience. And I believe this was an interesting time, and I believe we can repeat it many times to learn and to share experiences. Thank you so much, Dr.
Thank you so much.
For this very interesting session. Thank you for all the speakers, Dr. Asad, Dr. Shaima, and Dr. Ahmed, for these very interesting cases. And of course, it was a nice opportunity to have you with us today in our CME platform, and hope this to be to repeat these meetings in the coming days. Thank you so much. Thank you again, Dr. Rami, for being the coordinator of this session and for all of your work for CME chapter. Thank you for all professors for their share with great experience, and for all attendees for their active share questions and interactions and comments. What made this session really a very fruitful one. Use me to close, and we will take our Ramadan stop or Ramadan vacation and meet you, inshallah, after Ramadan, inshallah, and we'll announce about the coming meetings. Will be in our usual time in Wednesday, 9:30 inshallah PM, but after Ramadan. كل سنة وحضراتكم طيبين، وشهر مبارك عليكم جميعا، وعام حضراتكم طيبين.
كل سنة وانتم طيبين.
شكرا. كل سنة وحضراتكم طيبين جميعا. شكرا.
شكرا جزيلا.